There is a new dawn. And so knowing about this IDH mutation, which remember, we learned about in 2009, and here we are in 2024, now with a drug that actually targets this IDH mutation. That sort of gives you an instance of how long it takes for science to move things forward. And hopefully things won't take quite as long to keep it moving forward, but there's still an immense amount to learn. I think when we talk about these treatments, this is not a cure. And so as we continue to improve quality of life and help our patients live longer and better, we still need to be looking for more and better options and helping people live even longer and longer. So what is this new dawn about? So kind of going back to this discussion about what the mutation itself is. So it produces this 2-hydroxyglutarate. And again, that's an oncometabolite that actually we know it's an early event. So it happens in all of the tumor cells, and it seems to happen really early on whenever these tumors develop. And it creates cell division and growth. And this is also a mutation that exists in a couple of other tumor types. So patients who have a subset of leukemia actually have this IDH mutation in their blood cells, or patients who have gallbladder cancer. And so there were drugs that were developed for leukemia that were targeting this IDH mutation, because that was also found in about 2009 or so. So these are IDH inhibitors that are known to decrease 2-hydroxyglutarate and therefore slow down or even regress the growth of the tumor. And the first one that we knew about is called ivosidenib. It's a daily pill. It was approved in acute myeloid leukemia, AML, several years ago. And it targets a subset of these IDH mutations. This IDH1R132H is 80% of all tumors in gliomas that harbor an IDH mutation have this particular mutation. And so, really smart neuro-oncologists around the country said, well, if this seems to be really helping leukemia patients, and we know that this mutation exists in brain tumor patients, let's give it a try and see how patients do. It's a very well-tolerated medication. And so what they did is here on the right side, these are called waterfall plots. And here on the y-axis is percent. So above the line is growth. So something is increasing in size. Something below the line is decreasing in size. And these are slow-growing, non-enhancing tumors. And the blue shows that there were a subset of patients who received this drug who seemed to have progressive disease fairly quickly. And then many of these patients had stable disease, so a tumor that was growing stabilized, which is pretty exciting. And then even a few of them seemed to actually decrease in size. However, if you looked at tumors that had enhancement is sort of a marker of those higher grades. Grade 3 and grade 4 astrocytomas, oligodendrogliomas tend to also be enhancing. And so you can see that most of those patients didn't really seem to respond to ivosidenib. And so while some patients did actually stabilize for prolonged periods of time and even partially respond, many of these patients actually ended up progressing fairly quickly. And here's that Kaplan-Meier curve again. And over time, you can see that people with enhancing tumors didn't seem to do very well, which mirrors very much what we saw in their MRI. But these non-enhancing tumors, and these were people with recurrent IDH mutant tumors. So they may have had radiation, they may have had chemotherapy, but it seemed to be that we slowed things down. So this is progression-free survival. So how long are you stabilizing the tumor? And this number, 13.6 months, isn't overly exciting, I know, but certainly a lot longer than 1.4 months. And again, in a tumor that's growing, it's a signal. It's something encouraging. So there are a couple of these other IDH inhibitors. Enasidenib focuses on the IDH2, which is about 10% or so of all IDH mutations. And then vorasidenib, or now known as Voranigo, actually inhibits all of these mutations. So it's a pan-IDH inhibitor. So knowing that there was some preclinical work to suggest that this was well tolerated, mice tumors were slowing down, decreasing 2-hydroxyglutarate in their tumor. And so this is what they used to sort of move forward in comparison with ivosidenib with our next trial. Then to the development of this Indigo study, which is what landed us the FDA approval for Voranigo. So now we're taking patients with newly diagnosed. So none of these patients have had radiation. None of these patients have received any other type of chemotherapy. They've only had surgery. And those patients had surgery either at least a year ago, but no more than 5 years ago. So their MRI scans, you kind of had a sense of stability and you knew what was probably scar tissue from surgery versus what was probably tumor. And these patients were randomized and blinded either to receive Voranigo at 40 milligrams daily or a placebo. And the doctors didn't know and the patients didn't know. And everyone went on to receive MRI scans every 3 months. At some point, if there was concern about the tumor growing, then the doctor who was seeing the patient would raise a flag and the MRI scans were reviewed centrally. So not by the radiologist, which is very different from institution to institution, but by two people who were looking at all the MRI scans. And if they agreed, then the patient was unblinded. So then the doctor knows and the patient knows if they've been getting the vorasidenib or the placebo. If the patients had received vorasidenib, then the worry is that it wasn't working and they needed to go on to some other different type of treatment. That was a conversation between the doctor and the patient. But if they were receiving placebo, they were given the opportunity to cross over and start receiving vorasidenib. And remember, IDH mutant tumors often will be stable and growth can be controlled up to a couple decades. And so waiting to see if we actually improve survival, overall survival with these different techniques, the science is going to move along much, much, much faster. That's sort of this paradigm we've been living in over the last several years. So what they did was based on those MRI findings, they said, okay, well, can we stabilize these tumors? Can we stall their progression longer in patients who received the Voranigo versus those who received the placebo? So that was the primary outcome. And then the secondary outcome was time to new intervention. So essentially, how much change is enough change on the MRI scan to say, yes, we need, in fact, to do something different, not just watching it, but actually doing something different. And this is a very clinically relevant endpoint. They, of course, are capturing overall survival data, which we don't have those results of yet. And they're measuring quality of life, cognition, and seizure control. So we were really excited about the drug and also excited about the design of this trial and what it was going to teach us. And so these are the results. So everyone starts at the beginning, 100% of people are alive. And so the red is the vorasidenib, again, a slower curve. The blue is the placebo. These interim results were actually published in June of 2023. So it took us a year from when we knew this medication worked to actually getting it approved by the FDA. And what it essentially translates into is a 61% reduced risk of disease progression or death. And that really is pretty amazing. Similarly, when we look at that outcome of time to next intervention, which again is how much change is enough change to say, like, let's do something different. For the vorasidenib, which again is that red line, it's really flattened out. And a lot of it is not reached versus those with placebo who have grown. And I think what this has also taught us, even though people are getting placebo, I think a lot of these tumors are stable. They are definitely growing slowly over time. And so I think as we have these new options and new treatments, we'll be thinking about doing treatment earlier than waiting because the side effects of these medications versus another surgery or radiation sort of favor a little bit more of earlier treatment. And so this is a 74% reduction of the risk of receiving the next intervention. So 74% risk of needing to do something else